forward, right? It's about healing, it's about compassion, and it's about treating every single person with dignity. But what happens when that noble mission smacks right into a messy reality of unequal outcomes? When the genuine desire to do good doesn't always translate into actual good for everyone? Well, that's the provider's paradox. It's this deep, often uncomfortable conflict that sits right at the heart of modern medicine. Today, we're going to unpack it and, most importantly, find a path forward. And look, this isn't just some nice idea. It's the foundational promise of healthcare. This is literally Provision 1 of the Code of Ethics for Nurses, and it's a principle that rings true across all medical fields. It's the gold standard, really, a deep commitment to see and honor the humanity in every single patient, every single time. It's why most people get into this work in the first place. But then you see a statistic like this, and it just stops you in your tracks. Research shows that women with disabilities are 3 times more likely to be victims of rape. This isn't just a number on a slide. It represents a profound trauma that so many patients carry with them when they walk into an exam room. It's a harsh reminder that the world out there isn't equal, and those inequalities, they don't just disappear at the clinic door. So that brings us right to the heart of the matter. It's the big question we're tackling today. If the vast majority of providers are driven by this ethic of universal compassion, why do we keep seeing this persistent, documented evidence of unequal care? Disparities in everything from cancer screenings to pain management. It's this gap, this disconnect, and honestly, it can be really tough to wrap your head around. So let's dive in and try to understand it. Okay, so here's how we're going to break it all down. First, we'll really define what the provider's paradox is. Then we'll get into the psychology of something called implicit bias. After that, we'll look at how this stuff actually shows up in the exam room. And then, the important part, we'll explore real, concrete strategies for more equitable care. We'll finish up with a quick knowledge check and, of course, the main takeaways. All right, first up, the provider's paradox. This is all about that collision course between what we believe in our hearts and what the data shows is actually happening in practice. So there's actually a name for this feeling in psychology. It's called cognitive dissonance. As the research points out, it's that really uncomfortable, squirmy feeling you get when you're holding 2 completely contradictory ideas in your head at the same time. For a healthcare provider, it's the clash between I am 100% committed to treating everyone equally, and the data clearly shows that certain patient groups are not getting equal outcomes. And this slide lays it out perfectly. On one side, you have the conscious belief, what almost every single provider genuinely feels, this deep desire to give the best care to every person who walks through their door. But on the other side, you have these unintended outcomes, where the research shows time and time again that something below the surface, something we're not even aware of, is contributing to these inequalities. And because that cognitive dissonance feels so bad, our natural human reaction is to just push away the information that's causing it, to deny the evidence. But here's the thing. In healthcare, if we reject the evidence of bias, we miss a huge opportunity to get better. So this isn't about blame. It's about understanding how our minds work so we can do better. Okay, section 2. This is where we really get into the nitty-gritty. Kind of peek under the hood of our own minds to see what's going on. Let's unpack implicit bias. So what exactly is implicit bias? Well, the sources define it as those non-conscious prejudices and stereotypes that we all carry around. The best way to think about them is like mental shortcuts or habits of the mind. And this is super important. This isn't about being a bad person. These are things our brains learn automatically from a lifetime of exposure to our culture, to the media, to everything. They operate on autopilot without us even realizing it. This model here does a fantastic job of showing how these hidden mental habits can actually lead to real-world differences in health. And it's not just one simple cause and effect. Researchers have laid out 2 main pathways where implicit bias can really start to influence things. Let's break those down. So, you've got path A. That's the really direct one. This is when bias might directly influence a clinical decision, like a treatment recommendation. Then there's path B, which is a little more subtle, a little sneakier. This is all about how bias can change the way we communicate, the rapport we build or don't build, and the level of trust a patient feels. That negative interaction then leads to things like the patient being less engaged or less likely to follow a treatment plan. But here's the kicker. No matter which path it takes, they both end up in the same place: health disparities. All right, let's take this out of the theoretical world and put it right where it happens: the exam room. Let's see how these unconscious beliefs actually become tangible. So, researchers have actually measured this stuff, and what they found is pretty wild. They found that providers who scored higher on measures of implicit racial bias, for example, had measurably shorter visits with Black patients. They tended to talk faster, and they dominated the conversation more, which left a lot less space for the patient to actually talk. Now, these are subtle, non-conscious behaviors, but man, do they have an impact. And here's where the rubber meets the road. Patients absolutely pick up on these cues. Studies have found that Black patients in these interactions reported feeling less respected, they had less confidence in their provider, less trust in their advice. And this isn't just about hurt feelings. That lack of trust was a direct predictor of whether or not they followed their medical recommendations. This is how a subtle behavior can literally impact someone's health. And look, this isn't just about one specific group. The research points to these kinds of disparities across so many different populations. For instance, one study found that women with intellectual disabilities were way less likely to be up to date on their pap tests. Why? Well, part of it might be because of an incorrect assumption that they aren't sexually active. We see these same kinds of patterns over and over again in things like pain control, too. It's consistent, and it's troubling. Okay, so we've talked a lot about the problem, but the great news is we are not powerless here. These habits of mind do not have to be in the driver's seat. Research points to real, learnable skills that can help us all turn awareness into action. First up is a strategy called perspective taking. This is the thinking part of empathy. It's not just about sympathy, feeling sorry for someone. It's a real active mental exercise where you intentionally try to imagine the entire situation from their point of view. What are they worried about? What matters most to them right now? And the research shows that when we do this, it doesn't just reduce our own biases, it leads to higher patient satisfaction and makes them more likely to follow through with treatment. Strategy number 2, it's all about building a team. See, our brains are kind of wired to favor people we see as being in our in-group, so we can hack that a little. By using inclusive language, we can basically draw a new circle that puts both the provider and the patient on the same team. It's the difference between saying, I'm going to order this test for you versus, okay, what if we try this test so we can figure this out together? That simple little shift from I-you to we-us changes everything. And this third one, honestly, it might be the most overlooked, but also one of the most critical. Take care of yourself. Remember how we called implicit biases mental shortcuts? Well, when are you most likely to take a shortcut? When you're exhausted, stressed out, or totally overwhelmed. When a provider's mental battery is drained, their brain goes on autopilot. And that's when these biases can just take the wheel. So self-care isn't a perk. It's a core professional responsibility. When you put all these strategies together, what they're really pointing to is a bigger shift in mindset, a shift towards something called cultural humility. It's about letting go of the idea that you're the only expert in the room. It's recognizing that the patient is the world's leading expert on their own life, their own body, and their own priorities. Your role shifts from just being an authority to being a partner, a student of the patient. Okay, we have covered a ton of information. So what do you say we do a quick knowledge check? Just a few questions to see what's sticking. No pressure. Let's get started. First question for you, what is cognitive dissonance in the context of healthcare? Is it A, a disagreement between a doctor and patient? B, the discomfort from holding a belief like, I give equal care that conflicts with evidence that disparities exist? Or C, a type of communication barrier? And the answer is B. That's right, cognitive dissonance is that internal mental clash. And it's so important to understand because that uncomfortable feeling is what can motivate us to ignore or discount evidence that challenges our view of ourself, which is the first barrier we have to overcome. Okay, question 2. According to the research, a provider's higher implicit racial bias is associated with which behavior during clinical encounters? Is it A, longer visit times, B, slower, more deliberate speech, or C, more verbal dominance and shorter visits? The answer is C. The studies we talked about found those clear links between higher implicit bias and those subtle communication cues, like talking faster, taking up more of the talking time, and having shorter appointments overall with Black patients. Next up, the strategy of perspective taking is primarily about what? Is it A, understanding a patient's cultural background, B, imagining the clinical encounter from the patient's point of view, or C, taking a detailed patient history? The correct answer there is B. While all these things are important, perspective taking is that specific mental skill of actively trying to step into your patient's shoes and see the world, just for a moment, through their eyes. It's a huge tool for shutting down stereotypes before they start. Question 4. That retrospective study we mentioned found what kind of disparity in preventive care for women with intellectual disabilities? A, they were more likely to get PAP tests. B, they were significantly less likely to be up to date on PAP tests. Or C, there was no difference at all. The answer is B. And those numbers were just, wow, less than a quarter of women with intellectual disabilities were getting the recommended screenings, compared to almost half of women without that disability. It shows a really big gap in basic preventive care. And our last question, which of these language shifts is a great way to build a partnership with a patient? A, using more medical jargon to show you're an expert. B, asking more yes or no questions. Or C, using words like we and us to create a sense of teamwork. And the answer is, of course, C. That simple change in pronouns works wonders. It helps create that shared team identity, framing the whole conversation as a collaboration instead of a lecture, and that can really help push back against bias. Awesome job on the quiz, everyone. Now, let's bring it all home. We're at our final section, the takeaway. This is where we boil everything down into the key actions you can start using today. So if you remember just a few things from our time together, let it be these 4. 1, acknowledge the paradox. Just accept that having good intentions isn't always enough, and that these hidden biases are a normal part of being human that we have to actively manage. 2, practice perspective taking. Make it a real habit. Before you walk into that exam room, take 10 seconds to just consider their world. 3, build partnerships. Start listening for your own language and consciously shift to we and us. And finally, number 4, prioritize your own well-being. See being rested and mentally present as a critical tool for giving the best, most equitable care. So I want to leave you with one final question to think about. This isn't about doing a complete 180 overnight. It's about making small, intentional shifts. So what is one thing, just one tiny thing, that you can change in your very next patient interaction to build a better partnership, to see just a little more clearly through their eyes, and to start closing that gap between your good intentions and the best possible outcome? Because the journey to truly equitable care, it starts with that single step.